All right. Hello, everyone. Welcome to our diabetes wellness webinar for this month. I'm super excited to introduce Dr. Sandra Tsai. She is a primary care physician with a subspecialty in preventive cardiology. Her interests are cardiovascular disease prevention with a focus on hypertension, cholesterol, and glucose control. So I'll have her take over on her topic on keeping your heart healthy.
Hi, everyone. It's great to be here. And I'm hoping this can be interactive in the sense that if you guys have questions, definitely, let me know, because I want to make sure that as I'm going through it, things are making sense. But I'm happy to field questions during the talk. Okay, so we're going to talk about your heart. And the goals of this talk is really to help you understand what we think of when we say cardiovascular disease, and also this term called cardiometabolic disease, and to describe how atherosclerosis, also known as plaque, how it develops, and to help you understand what cardiometabolic risk factors are, and then discuss risk assessment, how you can assess your own risk and how we manage risk. So the first thing we're going to talk about is something called cardiovascular disease. So when we think about this, it's a pretty broad term. We include things like hypertension, coronary artery disease, stroke, heart failure, rhythm problems, specifically things like atrial fibrillation and heart valve problems. When a lot of people think about coronary artery disease, they think about these big arteries that are on the surface of our heart called epicardial arteries. And when we look on the left, this one's a normal artery, and you can see very clearly how big this lumen is. When people start to develop plaque or atherosclerosis in their artery, the plaque it's a lipid deposit plaque, and then the lumen, you can see here, the lumen gets smaller. And that's why people start to have symptoms, because the downstream blood flow is not as much when it needs to be, and so people will get chest pain. The thing about coronary artery disease is, so the picture that I just showed you is what most people think of coronary artery disease, but there's actually other types of heart disease. One is called microvascular disease. The other one's called endothelial dysfunction. So like I was telling you, the big arteries on your heart, they're the ones that are right on the surface of your heart. We call these the epicardial arteries because they're sitting right on the outside of the heart. But there's a really important structure that's inside and underneath the epicardial arteries, and they branch off from the epicardial arteries. This makes up this vast network of arteries called the microvasculature. You can't see these, and we can't see these. We really can't see these on an angiogram. They're too tiny. So we really, even when we do an angiogram, we're really only looking at the epicardial arteries. But the microvasculature plays a huge role in the diffusion of your blood. So that's another, and so those little arteries can become diseased, just like the big arteries can. Another type of heart disease is called endothelial dysfunction. So every single one of these arteries, down to even the microvascular ones, they all are made up the same way. They have an inner lining in here called and it's made up right here. It's called the endothelium. Okay, so that's the one cell layer right here. And when the endothelium becomes diseased or dysfunctional, it can allow plaque to lay underneath it. And also the endothelium is, things perfuse in and out of it, and it's responsible for secreting a lot of substances that help your arteries dilate. And so when your endothelium doesn't work well, you can also have constriction of your arteries when it really should be dilating, or maybe they don't dilate when they should dilate. So people can then feel chest pain because, again, the lumen is too small, and then people's blood flow, if the blood flow is not getting through. So what are the symptoms of decreased blood flow? This term is called angina. So angina is the term we use when we talk about chest pain that's due to a decrease in blood flow to the heart. And so for the most part, this presents itself as chest pain. So even though men and women, the number one symptom still of decreased blood flow is going to be chest pain. It can be described, though, as squeezing, tightness, just this pain that you can't describe. And the key here, though, is it tends to be exertional. So this is when you go and you walk, or you go up a hill and you get, chest discomfort, and then you stop and it goes away. You start again, it starts again, you stop, it stops. And so that right there tells you that as you're exerting yourself and as your heart rate's getting higher and your heart muscles need more oxygen, they're not getting it. So they tell you by giving you some chest pain. Some people don't have chest pain. Some people might have instead shortness of breath. They might also have pain in their jaw, their upper back, their left shoulder, left arm. But kind of the key is that it's exertional. It happens when you exert yourself. Now, this is the symptoms of angina, and heart attack symptoms are a little bit different in the sense that heart attacks can happen at any time. It doesn't matter what time they happen. They can happen anytime. You don't have to be exerting yourself. But heart attacks typically, what kind of makes them different, in that you will know that you should know that there's a problem, is that heart attack symptoms, oftentimes they won't let up and they get worse. Like if you don't do anything about them, they just nag you and they get worse and worse and worse. And that's when you should really be seeking help. And so that's called myocardial infarction. So that is actually a little bit different than angina, because heart attacks happen because when you have a plaque in your artery, if the plaque ruptures, the blood, like your blood, there are substances in your blood that will come to the plaque and they'll try and make it stop. And then that will actually cause a blood clot. And so that's myocardial infarction. And so that's actually right here. So they're blowing this up for you. So you can actually see there's a clot here, and then downstream, there's not enough blood flow. And so then that heart muscle dies. Again, like I said, chest pain, squeezing, pressure, it's like the symptoms are very intense. People can have an intense sense of fatigue, shortness of breath, they can have nausea, vomiting. And these are not things that you normally would get if you just have angina or this sort of exertional chest pain that goes away when you stop. You're not going to get nausea, but it can happen when you're having a heart attack, jaw pain, left shoulder, arm pain, back pain, maybe you break out into a cold sweat or even lightheaded. So I really like to tell people what heart attack symptoms are, because I want people to recognize when they need to seek help. And of course, when you have exertional angina, you should know that you need to seek help too. You need to visit your doctor because you need to figure out, like, what's going on? Why am I having this symptom? Cardiometabolic disease is a term that some of you may have heard, but this is where we're really trying to combine this understanding that the heart and your metabolism or glucose metabolism are really tied together. And so when you have glucose metabolism problems, it sets you up for having heart problems or cardio problems. So we call this cardiometabolic disease. So there are several stages that we go through. So when people are metabolically healthy, they're at stage 0. Stage 1, they've accumulated 1 or 2 risk factors, maybe, and they start noticing that their blood pressure is high, maybe their triglycerides are high, their waist circumference large, and their HDL is low. And then people, if they have that for a while, and then they'll develop something called, or maybe they'll get multiple ones of these, and then we diagnose them with something called metabolic syndrome, where you get a constellation, multiple of these risk factors, not just 1 or 2, but 3, 4, 5 of these risk factors. If you can also be diagnosed with prediabetes, is where you actually have your A1C is elevated, plus you can have all these other risk factors, and then we diagnose you as stage 3. And then stage 4 is where you are diagnosed with type 2 diabetes, or maybe you've been diagnosed with a heart attack or stroke. That's like the highest stage of this cardiometabolic disease spectrum. And it really the center of it all is insulin resistance. And this is when your insulin it's not working in your body as well as it normally should. So when we eat food, glucose is absorbed into our bloodstream here. So, it's absorbed through our stomach, it gets in our bloodstream. And then the glucose, when everything's working normally, the glucose is sent to the liver, because your pancreas secretes insulin to say to these organs, hey, organs, I've got some glucose and you should take it up. So the insulin talks to these and brings the glucose here. So that's completely normal. When people have developed something called insulin resistance, everything works the same here. But then once the insulin is speaking to these organs, they're not really listening as well. And so you can see here that the amount of glucose that's moving into them has decreased. Like it used to be, you can see this is just a picture of it, but it's just to imagine that the glucose is not moving as efficiently into these organs for their use. And so because of that, the glucose remains in the bloodstream. And depending on how much glucose is in your bloodstream, you may get diagnosed with prediabetes or type 2 diabetes when it's even higher. And the A1C for prediabetes is 5.7 to 6.4%. And when it's diabetes, it's 6.5 or higher. And now we're going to kind of move on and talk about, well, how is insulin resistance related to all of this? So insulin resistance typically, it can happen for several reasons, but the main reason it happens is because we gain too much fat inside of our abdomen cavity, and we call that visceral adiposity. Adipose is just fat, and adiposity is this what's happening, and the visceral is in the middle of the abdomen. So for women and men, we can kind of tell this by their waist circumference. So these are the cutoffs for waist circumference to be considered normal. So female should be less than 35, male should be less than 40. Asians have lower cutoffs. Female should be less than 31, male should be less than 35 inches. Body mass index is also a little bit, this is also another proxy, but not as good as waist circumference. So waist circumference is better because it's literally measuring your waist, and it's measuring sort of how big the waist is. BMI is a proxy, or sort of this quasi measurement for how much, excess adipose tissue you have. And these are the cutoffs for that, is that normals considered less than 25, for Asians less than 23. And so what's really dangerous is when we start to gain weight like an apple, where it's again in the middle, as opposed to a pear where it's mostly in your thighs or the buttocks. That's actually safer because the waist circumference, as you can see here, is a little bit smaller. But once we have visceral adiposity, that is a risk. That is what causes insulin resistance to happen, is what's happening inside of your abdomen. Because what we know now is we know that adipose tissue is not just inert. It's actually super active. When we have too much adipose tissue, it's secreting all sorts of substances. And one of the things that's happening when we have a lot of adipose tissue in the visceral area, or visceral adiposity, is inflammation. And so inflammation is a normal process. We need inflammation. It's our typical process for our immune system and our white blood cells to fight off things like an infection. The problem comes if we are in a chronic state of inflammation. It's a problem for our bodies. Instead of having an acute inflammation that takes care of the problems, now we're living in a state of inflammation. And these inflammatory factors, they play a key role in linking your cardiovascular risk factors to the development of plaque. So inflammation is a key player in all of this. And so this is just a picture of sort of how this happens. Like, this is that one cell layer I was talking about, this endothelial layer. And this is a cross section across an artery. So this is sort of the lumen, or the blood. And what happens is, if you've got inflammation, the immune system, and it's things like the monocyte, this is like an inflammatory marker, or a cell. These cells can actually come and pull in lipids into, like you can actually see here, it's actually pulling in, these will come into the other side of the lumen, onto the tissue side, and it'll actually pull in lipids. And then over time, it actually starts to form a lipid layer, or a plaque underneath here. One of the ways that we measure inflammation is through inflammatory markers. So we do have something called a high sensitivity C-reactive protein marker, which can tell us how much inflammation you actually have in your body. And we use this particular marker to help us understand your risk, because if we know that if you're very, very inflamed all the time, we know that you're going to be at higher risk for forming plaque. So this is how plaque develops, and it starts really early in your life, in a person's life. So this is the inside, again, cross section of a lumen, and this is healthy. There's nothing buried underneath. You can tell that it's really nice and thin right here. And then when people start to form a fatty streak, it starts to get thicker. You can see this lumen is starting to get a little bit more narrow. And then over time, it can develop into an atheroma, and it grows and grows until it gets thicker. And so you can actually see here, the lumen has narrowed because this plaque over time has gotten bigger. And for some people who are very high risk for developing plaque, they develop it in the first decade of their life. And so they can have heart attacks as early as in their 20s, 30s, 40s, because they've already developed some plaque. And again, like I was saying, what happens is if this plaque opens up and ruptures, that's when a blood clot can happen here and block off the lumen, and you can have a heart attack. So one of the things about cardiovascular disease is we try to, at every stage, prevent. And prevention is a spectrum. And so this first part of the spectrum is primordial, which basically means that we try to prevent you from developing any of the risk factors. Okay. For example, we try and prevent you from having high blood pressure or abnormal cholesterol. So that's the primordial stage. Primary prevention is the stage where, okay, now you've developed a risk factor, let's say diabetes, and now we're going to manage it. We're going to control it as much as we can because you haven't had a heart attack yet, and now we're trying to prevent it from happening. Secondary prevention is where perhaps you've had a stroke or a heart attack. Now we want to prevent it from happening again. So we're going to manage the risk factors very aggressively, even more aggressively than in primary prevention, and make sure that we can try and prevent it from happening again. So in terms of guidelines for prevention, we first try and assess your risk. How high of a risk do we think you are for having a stroke or heart attack? Then we really work on lifestyle, because lifestyle is an extremely important component of preventing cardiovascular disease. And we use medicines. We've got a lot of really good preventive medicines that we use to prevent heart attacks from happening, and for the first time and subsequent times, and also to control your risk factors. So let's talk about risk factors. So there's actually quite a few risk factors, but I like to break them up into two main buckets. The first bucket on the left, these are buckets. This bucket is non-modifiable. You can't really change this section, but helping to understand that helps us understand what your risk is. Your age, the older you are, the higher your risk. Your sex, both men and women have just as much heart disease, but men have it younger than women typically. Women tend to have it 10 years later than men, but they have just as much as men. Family history of premature cardiovascular disease. This basically means that if you have a first-degree relative, mother, father, sister, brother, they're only 1 degree separated from you, and they had their heart disease or stroke early. So that would be first-degree relative male, less than 55 years old, first-degree female, less than 65 years old. If you have a family history of premature cardiovascular disease, that is very, very important. And you should definitely be letting your doctor know, because we tend to treat you much more aggressively because we put you at higher risk. Modifiable risks are here on the right. Smoking, having high blood pressure, having abnormal cholesterol, having diabetes, having a poor diet, not moving much, having obesity, having chronic kidney disease. These are all things that we can change and we can improve, and that can reduce your risk. So that's what we're going to work on. That's what we're going to sort of talk about today, because these are the things that we can control. In addition to those things, I often get asked about stress and how stress plays a role. And stress does play a role. So psychosocial stressors are associated with an increased risk of cardiovascular disease. So this particular study is called the Inner Heart Study. So this is a very famous study that included 52 countries around the world. And what they looked at is they looked at all the different risk factors that were associated with the first heart attack in people. And what they found was that these 9 modifiable risk factors here in these graphs accounted for 90% or more of the first heart attack. That sort of tells you that the majority of cardiovascular disease is preventable, because these are modifiable risk factors. Okay. One of the things that I wanted to point out is right here, psychosocial. This is in terms of population adjusted risk. This just kind of tells you where these are rank ordered. Okay. So psychosocial is pretty high. It's actually, it's below lipids, but it's just behind smoking. You can actually see here, smoking we know is a big risk factor, but it's right behind that. So that's pretty significant. And you can see here that it's even above hypertension. Having said all of that, I will say that depending on what country you live in, sometimes psychosocial factors are a lot higher than if you are in a developed country. So, but really, this is really just to kind of tell you that stress makes a difference. Okay. The other thing I wanted to talk about is I think probably the majority of you have been diagnosed with diabetes, and maybe at least prediabetes. I'm not sure, but We use screening tests for people who we're still not sure what their risk is. But I'll just put it out there that if you've been diagnosed with diabetes, you're at extremely high risk. As you saw in the cardiometabolic profile, you're already in stage 4. So we don't tend to use a lot of screening tests. When you're in stage 4, we just treat you super aggressively. Okay, but what are some screening tests? I already talked about one of them, which was the high sensitivity C-reactive protein. So this is, again, an inflammatory marker. And there was a big trial called the Jupiter trial that enrolled 18,000 people who at the start had no cardiovascular disease. They randomized them into 2 groups. You either got a cholesterol medicine called rosuvastatin, or you got placebo, you got nothing. And in order to enter into this trial, and actually what they did was they measured your cholesterol to start, and they also measured your HSCRP. And they looked at people who had high cholesterol and elevated inflammation, and they actually wanted to see, does it make a difference to treat you with this cholesterol medicine? And they actually had to stop the trial early because after 4 years, there was a 44% reduction in primary endpoint, which basically meant that in people who had inflammatory markers that were above 2, which we considered to be slightly inflamed, we were able to reduce their risk of having a heart attack by 44% by just giving them a cholesterol medicine, even though their cholesterols were not all of them were high. It's just that these were people that, because they had inflammation and very high risk, they benefited from being on a cholesterol medicine. So the first screening test is your inflammatory marker, just to understand what your inflammation is. Another one can be, even without symptoms, if we're looking to see whether or not your blood flow to your feet is good, we're also, oftentimes we're looking to see how good your pulses are in your feet. If we don't feel good pulses in your feet, often your doctor will ask you to get something called an ABI, or an ankle brachial index test. And what this test is basically doing is it takes blood pressures in your arm, it takes blood pressures in your feet, and it basically looks at the difference between the blood pressure in your arms and the blood pressure in your feet. Because as you can see here, when your heart pumps blood, it pumps it everywhere. And if you've got blockages somehow distally towards your feet, the blood pressure is not going to be very good. It's going to be lower. And so we'll see that differential. So what's normal is getting a score greater than 0.9. What's abnormal is something less than 0.9. And if you have a score less than 0.9, it tells us that you have evidence of atherosclerotic disease in the arteries leading down to your feet. And even if you don't have any chest pain or stroke symptoms, it can be the first sign that you have plaque. And one of the biggest risk factors for people who have an abnormal ABI is actually not something harmful to their legs, but that they're going to have a heart attack or a stroke. Okay, so this kind of can be used as a screening for heart disease and stroke. Another one is coronary artery calcium scan. So this particular scan is a CT scan. And what this scan does is it specifically looks for calcium in your heart arteries. I put on here the amount of radiation, which is 1 millisievert, which is considered a very low amount of radiation. So when I recommend this for people, what I'm really trying to figure out is whether or not they have a lot of plaque. Because if you have a high calcium score, it is equal to or associated with a high, with plaque, essentially. If you've got calcium, you definitely have plaque. And where you have calcified plaque, you've also got non-calcified plaque. So a calc score of 0 is considered completely normal. And we tend to use this particular scan in an intermediate risk population. So typically we're not going to use it in a population of patients who have diabetes, because we already know you're very high risk. But if you have pre-diabetes, for example, you might be sort of fit in this more intermediate risk population, and a calcium score might be helpful for you. If your doctor feels like they still need to understand a little bit more about what they think your risk is. So it does improve risk stratification, because if you've got calcium, your risk is higher than, and depending on also your calcium score, we can actually figure out how high your risk is. We consider a calcium score of 0 to be normal, less than 100 to be mild, 100 to 300 to be intermediate, and above 300 to be pretty severe. So here is just pictures of what we would see on a CT calcium score. So this is, again, literally a cross section across your chest. These little, I showed you those epicardial arteries that lay on top of your heart. So these things here are basically arteries that are coming off the heart that we can see. And these are your, this is calcification. So calcium always shows up white on a CT scan. The one thing I will also mention is that for a lot of people, if you, for whatever reason, get chest CTs, for whatever reason, the chest CTs, even though they're not coronary artery calcium CTs, if they're just chest CTs looking at your lung, because your lung your lungs are on the other side of your heart, they will see your heart too. And so a lot of times people will get, we'll see your coronary artery calcium incidentally on your CT scan because you had one. And so a lot of times your physician will even say to you, oh, I saw that you had calcium in your heart arteries. Let's talk about that. And so that's actually something that once you've got calcium, you've got plaque.
So we actually have 2 questions. So one is, how often does a calcium scan need to be repeated? And then secondly, is the calcium in the arteries correlated with dietary intake of calcium?
So in terms of the calcium score, we use the calcium score in only certain situations. One situation is if you're not already on a statin, then we'll use the calcium score. And if you get placed on a statin because you have a positive calcium score, we don't repeat the calcium score, because the calcium score is really to help us at that fork in the road. Do we or don't we need to lower your cholesterol? Do we or don't we? And once we've decided, then we don't repeat it again. Then there are other tests that we may need to do down the line, but not a calcium score. The second question is, there has been some data that associates people who take calcium supplements. There seems to be a higher correlation with coronary artery calcium if you take calcium supplements. So anytime we ask you for your bone health to take calcium, we prefer that you get dietary calcium, that the calcium come from your diet, not solely from a supplement. But of course, you do it the best you can. If you need to take a supplement in order to get your calcium needs because of your bones, we want you to do that. It's just that there's a correlation, but there's no causation. Okay. It's not causative. It's just there's an association. Okay. Any other questions?
That's it for now. Thank you.
Great. Thank you. Those are great. So thank you for asking those. So in terms of risk factor, let's move on and talk about, well, let's say you've got some risk factors. What should we do about them? I want you guys all to know about the American Heart Association. So the American Heart Association has a wealth of information that if you want to learn more, please visit their website. 1 or 2, maybe a year and a half ago, they developed something called Life's Essential 8. And so this is basically the 8 lifestyle factors that are really important to prevent heart disease. Your diet, exercise, your glucose, your weight, your cholesterol, your blood pressure, whether or not you smoke, and how much sleep you get. So we're going to talk about those. But I want you guys, I actually encourage you to go to this website and learn a little bit more about Life's Essential 8. The one thing I'll also mention is they didn't mention anything about stress, but we know stress matters. So I sort of put plus, I want you to manage your stress. So in addition to those essential 8s, let's talk about stress. So stress is one of those things that life happens to us, and we can't change everything that's happening to us around us, and that's okay. It's about managing what happens inside your body and inside your brain and how you think about it. Because if you don't manage it, it will internally damage, it will internally bother. It'll start to wreak havoc in your body. One of the best things you can do to manage your stress is exercise. I can't stress enough how important it is to you in general, exercise. Now, other really great ways to manage your stress, mindfulness-based stress reduction. This is also known as MBSR. Fantastic technique that you can learn, meditation and yoga. Okay, so let's talk about exercise. I just want people to know what's the minimum you need to do. So the minimum is at least 150 minutes per week of a moderate intensity activity. Plus, so you say that, and muscle strengthening activity, at least 2 days per week. You need to be doing something that builds your muscle. It cannot just be walking. It can't. It needs to be more than that, okay? Because if you lose muscle, you are going to increase your insulin resistance. Your insulin sensitivity goes down when you don't have enough muscle. But don't stop at 150 minutes. Keep going. 300, the data shows us that if you do more, you can get additional benefits. We also know that exercise has been associated with a 30 to 40% lower cardiovascular disease risk. So this just tells you that exercise is so powerful for reducing your cardiovascular risk. We've seen, and now a lot of these are observational studies, so these are associations, but there's lots and lots of observational data that shows us this, that there's an inverse relationship between physical activity and cardiovascular disease. What does that mean? That means that when you do more exercise, you lower your risk. If you do moderate intensity exercise, 20 to 25% reduced risk. Vigorous intensity, 30 to 35. That's why the guidelines say, hey, if you can do more, do more. It also, despite the cardiovascular disease risk reduction, it can improve your blood pressure. For some people, it's a vast, a nice, huge reduction. For others, less. So, but on average, I would say 5 to 8 millimeters of mercury, especially for those of you who have a difficult bottom number in your blood pressure, like that diastolic is really stubborn. Aerobic exercise really helps that diastolic even more. Exercise also improves your insulin sensitivity. So many of you have probably noticed that if you take insulin on a day that you exercise, you need less insulin, or and that's because when you exercise, it improves insulin's sensitivity, which means that when your organs are getting a signal from insulin, they're going to listen to that insulin a bit better if you've been exercising. This is a wonderful graphic of what insulin sensitivity does when you exercise. Okay, so let's just this is a hyperbolic curve, which basically means that on either side, it's sort of not linear, is like sort of straight like this. So it's a hyperbolic curve. And what this is on the y-axis is insulin secretion, on the x-axis is insulin sensitivity, which basically means that the more and more sensitive your insulin is, the less insulin secretion. The less insulin sensitive, the more your insulin secretion. Okay, so that's a hyperbolic curve. So if we just take a normal person, if a normal person with normal insulin sensitivity and no prediabetes or diabetes, if they're sedentary, they go up this hyperbolic curve, their insulin sensitivity goes down and their insulin secretion needs to go up. Okay. When they become more active, their insulin sensitivity improves, so they get to secrete less insulin or use less insulin. When you move, this hyperbolic curve moves to the left, because when you have prediabetes and diabetes, you already usually have decreased insulin sensitivity. So it's so important that you are active. I wanted to bring up sarcopenia, which is this term that as you get older, especially after the age of 30 and then after 50, it really accelerates, but we start to lose our muscle mass. So if you don't do anything to combat this, you are going to lose your muscle, and it worsens your insulin sensitivity. So muscle mass decreases approximately 3 to 8% per decade after the age of 30. It's accompanied by an increase in fat. So it's not that your muscle converts to fat. It's that when you lose your muscle, oftentimes what replaces it is going to be fat. It increases our risk for insulin resistance with aging and but on the other hand, if you increase your muscle mass, you increase your skeletal muscle and the glucose uptake, and then improves your insulin sensitivity. Okay, so we talked about exercise, how important it is, but it's just as important not to sit for long periods of time. So the average adult spends more than 7 hours doing sedentary things, working, watching TV, whatever, meetings, for example. And this just sitting worsens our cardiometabolic risk patterns. And it's even worse for people who don't exercise. So if you don't exercise and you sit a lot, it's even worse. So regardless of your activity level, prolonged and uninterrupted sedentary behavior increases your risk for all-cause mortality, which basically means that if you sit for a long time, you're at greater risk for just dying, not just from dying of cardiovascular disease, just dying. Okay. So this is a great, I think, way to sort of look at daily sitting time and its relationship with moderate to vigorous physical activity. And this is from the Physical Activity Guidelines for Americans from 2018. So let's just start here where when someone doesn't sit much, so you can see their daily sitting time's very low, but they exercise a lot. So they're going to be on the right lower hand corner. You can see it's all green. Their risk is it's good. Because they're at the lowest risk for having cardiovascular disease and mortality. Let's take the opposite. This is someone who doesn't do any exercise, but sits all day long. You can see it's all red in here. And the interesting thing about this is that for people who sit a lot, okay, let's say they sit a lot, so they're up here, but they also exercise, you can actually see they're still kind of yellow. So you can see that kind of tells you that the sitting itself is so harmful that even like exercising can't take it all away. You can actually see it doesn't take it completely away. So we really need to work on both. Okay, the next thing is let's talk about diet. Diets that are high in fiber or very, very plant forward, that's the evidence shows us that these diets are the diets that are going to be most associated with a lower cardiovascular risk. So if you're plant forward, you don't have to it's not that you have to eliminate meat. It's just that your diet needs to really have a lot of plants in them because fiber is so protective. So high fiber diets look vegetables, fruits, whole grains, legumes, beans, lentils, that sort of thing. And then research has showed us that diets with less meat have been shown to lower your cardiovascular risk. And there is this very clear link between a very healthy plant-based diet and cardiovascular health. So when I say plant forward, a lot of vegetarians can have a horrible diet. They just don't have meat because it's very processed. That is not what I'm talking about. I'm talking about high fiber because if it's processed, it's vegetarian and low fiber. I want vegetarian high fiber. That's going to be your plant forward diet. There's a lot of evidence for the Mediterranean diet reducing your cardiovascular risk. And this is another fantastic study called the PREDIMED study. So in nutrition science, a lot of it's observational, but this was actually a fairly large randomized control. So this is an RCT that would happen in Europe. This is called the PREDIMED diet study. And what they did was they took 7,500 people, no known cardiovascular disease at the start of the study. They randomized them and followed them for 5 years, randomized them to either the Mediterranean diet or a low-fat control diet. And what they found was people in the Mediterranean diet had a 30% reduced cardiovascular risk. Now, the Mediterranean diet is, like you can actually see here, the base is full of fibrous things, and they do eat, fish and seafood. They have some eggs, cheese, yogurt, and in terms of actual meats and sweets, much less often. That's a Mediterranean diet. Okay, so that's kind of what to eat, but what not to eat. Okay, so what not to eat. Sugar sweetened beverages and artificially sweetened beverages. I get this question a lot about whether or not artificial sugar is okay, because I think for a lot of people who are trying to reduce their sugar intake, they'll sweeten with artificial sweeteners. The problem with artificial sweeteners is there's more and more data showing the harms of artificial sweeteners. They stimulate the brain in the same way that sugar does, and they can still stimulate the insulin production. And so in general, trying to get your palate used to less sweet things in general is better. Of course, saturated fat, you eat a lot of saturated fat. This mostly comes from animal products, and animal products like beef, pork, and dairy. And these things really can raise your LDL cholesterol. Trans fats largely come from, trans fats in general are supposed to be out of our food, but a lot of the partially hydrogenated vegetable oils, those aren't processed foods, those are still around. So if these make your foods shelf stable, like if you eat chips or something, they usually will have a lot of hydrogenated vegetable oils in them. We want to limit our alcohol intake. Less the better. In general, I would say for women, for sure, less than 1. For men, for sure, less than 2 glasses per day on average. Less sodium, especially for hypertension. Sodium is a big reason why people have hypertension that's not controlled. And then cholesterol. So cholesterol is in certain types of foods like eggs and shrimp and shellfish. And cholesterol oftentimes can be embedded and very hard to separate what effect cholesterol is having and saturated fats having on your cholesterol. But in general, I would say cholesterol foods probably have less of an impact on your cholesterol. So if I were going to have you limit anything, I think the first thing is let's try and work on limiting your saturated fat, because that'll help lower your cholesterol or your LDL cholesterol. The next thing is what the American Heart Association did is when they made the essential 8, they added sleep as the 8th metric, because there's lots and lots of evidence that getting too much or too little is not good for you. So we know that insufficient sleep is linked to obesity, metabolic syndrome. It affects your appetite, your hormones. It's associated with fatty liver. And so one of the things is, if people get 7 to 9 hours of sleep and they still wake up tired, that is a sign that there's something wrong, and that you really do need to approach your practitioner or your PCP and ask them about whether or not you should be evaluated for sleep apnea. But I usually would, especially if you've got diabetes. There's a lot of people with diabetes have sleep apnea too. If you have trouble falling asleep, this is called insomnia. There's a very good treatment for insomnia called CBT, also known as cognitive behavioral therapy. It's the first line treatment for insomnia. And so I would also ask about this if you have any insomnia, just so we're trying to help you get enough sleep. And another good sleeping habit is to make sure that you have regular sleeping, like go to bed times and wake up times. The next thing is, I really want people to know what their blood pressure should be. So blood pressure is one of those things that we absolutely can control. And it's such a huge risk factor for stroke and heart disease. So a blood pressure of less than 120/80 is normal. But if you've been diagnosed with hypertension, our goal is to keep you at less than 130/80. Okay. It's super important, if you've been diagnosed with hypertension, that you know how to monitor your blood pressure at home. It is so important that you own a monitor. It's $35. I think everybody should be able to afford this. And if not, I think the Stanford Health Library has monitors that you can loan, just so you can monitor your blood pressure at home. This, again, you can go to, this one is I think the American Heart Association has tells you about how to normally how to properly take your blood pressure at home. But typically you should be seated. Your arms should be about heart height. You should have relaxed for a few minutes, and then you measure your blood pressure. There are, of course, non-medicine ways to help with your blood pressure. Weight loss helps, a healthy diet, reducing the sodium, and enhancing, and also potassium. Okay, so a lot of people do not know this, that sodium and potassium sort of are opposite of each other. Like sodium will raise your blood pressure. Potassium actually lowers your blood pressure. So if you eat a diet that's very, very rich in it's like you have a high fiber diet, that a lot of those foods are very high in potassium. But you can also Google or look up, like, what are some high potassium foods, like avocados, sweet potatoes. These things are very high in potassium. If you put them in your diet, it will help lower your blood pressure. Physical activity, like I talked about, and moderation of alcohol.
We have a question regarding, for the sleeping slide, do naps get included in that, the total hours?
Yeah, I would include naps. The one thing I will say about naps is that, so I think naps are fantastic for people who need them. But the thing about naps is, it's kind of telling me, the fact that you need a nap, it kind of tells me that let's make sure that your sleeping is okay. Let's make sure there's nothing wrong with the actual sleep that you get at night. For some people, it's actually quite normal for them to get 5 hours at night. They wake up feeling great. That's just great. But then they need a nap. And that's okay. If that's the pattern, that's okay. But most people, when you sleep, after you've slept at night, you should wake up and you should feel good. Okay. That's really kind of key. Very important, is that you should wake up feeling good. Okay. But yeah, I would lump that in to your 7 to 9 hours. Okay.
Great. Thanks for clarifying. And then one more question relating to cholesterol. So even if someone does not have high cholesterol, is it possible for plaque to develop?
Yes, it is. So because cholesterol is in plaque, or lipids are in plaque, what sets you up for plaque development is multiple things. A little bit of genetics, high cholesterol, high blood pressure, diabetes, multiple risk factors sort of set your endothelium up to be unhealthy. And once it's unhealthy, it's vulnerable. It's vulnerable to plaque. And so that's why when we talk about risk factors, it's trying to control these to as much as we can, because we're trying to improve our endothelium. And the lower you get your cholesterol, there's just less lipids to make plaque, essentially.
Great, thank you.
So in terms of cholesterol, these are the ideal states for cholesterol, and I just kind of wanted to go over them. So your total should be less than 200. We talked about this bad cholesterol, LDL, it should be less than 100, but that's for like people who are not at really high risk. That's for like the average person. I always want their LDL cholesterol less than 100. But if you've got diabetes, I've got stricter criteria for you. LDL cholesterol, this is for men. It needs to be above 40, for women above 50. Triglycerides less than 150. But the thing about triglycerides is the lower, the better, because triglycerides are they're like a marker of your glucose metabolism. So the higher triglycerides, the worse your glucose metabolism. So even though it's not glucose, the insulin has a control over triglycerides too. And so we often see them rising together. So if you've got bad diabetes control, your triglycerides are typically going to be high. Okay. Your non-HDL. So you can find your non-HDL by taking your total cholesterol and subtracting your HDL. And then you'll get this number called the non-HDL. And the non-HDL needs to be ideally less than 130 or lower. And the reason why we care about it is because all the particles, your lipid particles that are not your HDL particles, are bad. Okay. So we want them low. And so that's why, so the higher your HDL goes, the lower your non-HDL goes. Okay. So you kind of see I just want you to kind of understand the components of cholesterol because they all matter. Okay. So if you've got diabetes specifically, again, I would put people with a diagnosis of diabetes, you have stricter criteria. So in general, I would say the guidelines tell us that people with diabetes need to be on lipid lowering medicine, and the medicine tends to be a statin. And we tend to want your LDL to be less than, I would say less than actually what the guidelines tell us is if your LDL cholesterol is 70 or above, you should be on a lipid lowering medicine, and we should try and get your LDL at least 30% reduced. Okay. And at a minimum, it needs to be less than 100, but ideally lower than that. Okay. Just from all the things that we've sort of talked about. If you've ever had a stroke or a heart attack, we're going to want your LDL cholesterol less than 70. Okay. I just wanted to touch on medications a little bit because they're very important in terms of prevention. The first one is the statins. And I want people to know how these work. So the way statins work is this is usually the number one thing we're going to ask you to start. And it's because it's generic. It's been around for 4 decades, so 40 years. We've got a lot of research behind statins. We have unequivocal data that in primary prevention and secondary prevention, it is helpful. And the lower, the better in terms of your risk. But the way it works is it blocks the production of cholesterol through your liver. That's how it lowers your cholesterol. The next one is ezetimibe. So for whatever reason, if you need to take another cholesterol medicine, or maybe you can't take a statin for some reason, we might add ezetimibe. So this one works by preventing cholesterol reabsorption. So this one works in your small intestines by preventing the absorption of cholesterol. And so it doesn't cause, or typically does not cause, muscle aches because it works inside of your GI tract as opposed to being absorbed and floating around your bloodstream. PCSK9 inhibitors are the third line of treatment for people. So these are monoclonal antibodies. And what these do is they prevent the degradation of what we call the LDL receptor. So LDL receptors are receptors that are on the surface of your liver cells. And what they do is they are trying to pull in LDL cholesterol to be recycled. And so what happens if PCSK9 inhibitors, what they do is they prevent LDL receptors from themselves from being recycled. And so by that, you'll end up with a lot more LDL receptors on your cell surface, and then to bind your LDL, and that's how it lowers your cholesterol. Okay, let's talk about aspirin. So aspirin plays also a very important role, largely in secondary prevention. You've already had a stroke, you've already had a heart attack. In secondary prevention, I've listed it here. In secondary prevention, the benefits of aspirin largely outweigh the risks of aspirin. So in secondary prevention, it's very clear. We put you on aspirin. Primary prevention, where you haven't had a heart attack and you haven't had a stroke, aspirin's a little trickier because statins and lowering your cholesterol is so safe that we typically will want to lower your, that's the safest thing to do. The safest thing to do is to lower your cholesterol and lower your blood pressure, control your diabetes, all of those things, because aspirin's risk is bleeding. Typically it's GI bleeding, but it can also be brain bleeding, but typically it's GI bleeding that we worry about. So, but in primary prevention, if you're between the ages of 40 and 70, and you have a very high risk for cardiovascular disease and no increased risk for bleeding, we may consider using aspirin for you. But for people who are older than 70, we really generally do not use aspirin routinely unless we have a really good reason. And anyone who's got an increased risk for GI bleeding, we also don't use aspirin. So here's two caveats. So there are times where you can get diagnosed with something called an elevated lipoprotein little a. So lipoprotein little a is a LDL particle. The structure is exactly like an LDL cholesterol particle, but it has an extra moiety on it, which changes it and makes it more atherogenic. So if you've got a lot of lipoprotein little a particles, you're more likely to lay down plaque than if you didn't. And this is genetically determined. This is something that usually you'll inherit from one of your parents. And we tend to check this in people who have a family history of premature atherosclerosis. So if you've got a family member who had early heart stroke or heart attacks, we often will check a lipoprotein little a, because we want to know, is this the reason why your parent or whatever had an early heart attack or stroke? And if you have it, then we treat you more aggressively. So if you have an elevated lipoprotein little a, aspirin may be reasonable for you. And also if you have a calcium score over 100, again, aspirin may be reasonable for you. So I just wanted to make a little bit about aspirin for that. So the take home message is that cardiovascular disease is preventable. It's really important that you understand what your risk is, and that once you understand what your risk is, that you work at reducing your risk, because for every risk factor you get under control, you just lower your risk more and more and more. So lifestyle is absolutely foundational. That's the number one thing. People should be regularly exercising, eating plant-forward diets as much as possible, glucose control. Depending on what your PCP or endocrinologist has for you, typically the goal is to get you less than 7. Some people have a less than 8% goal. It sort of just depends on what else is going on. We talked about aspirin and also lipid lowering therapy, such as statins, for people who have diabetes, diagnosed with diabetes and an LDL greater than 70. And that's all I have. And I'm happy to take any questions.
Great. Thank you so much for the well-rounded presentation. We do have some questions. So one is about specifically in the population for postmenopausal women. How do you get a balance between adequate and sufficient consumption of good quality protein while also reducing meat intake?
Oh, so there's great plant protein. There's, and again, Catherine here has great advice, but I think that anytime I ask one of my patients to change their diet, I will absolutely send them to someone like Catherine, because I do want people to understand it's very important that you get enough protein, but you can still get protein from plants. You can do that. And just understanding how to do that. And so that's generally what I would recommend, is that you visit with a dietitian.
Great. Thank you. And then someone else is asking, when do you get an inflammation test? And I think they're referring to the CRP.
Yeah. So you can ask your doctor to order, or your nurse, or the APP who's taking care of you, to order an HSCRP for you. I think, the reason I tend to use it is I use tools like this to try and help people understand, and also to help motivate people. Like, for example, if you've got a lot of inflammation, and I'll just give you one example, like for people who have diabetes, it's inflammatory state, especially when your diabetes is not well controlled. It's a lot of inflammation, and you can see that on your marker. And then if you say to yourself, gosh, my HSCRP is like 9, I don't like that, I'm going to try and reduce that. I'm going to start exercising. I'm going to eat better. And then we check it again and we see, oh, wow, you dropped it to 4. That's fantastic. So it's stuff like that. But that's how you get it. It's a blood marker. It's a blood test.
Got it. And see if anyone else has questions. We'll wait another minute. Please enter them in the chat box or the question and answer box.
Oh, and also there's one question that says, what is the strict LDL limit? Did I answer that one yet, Catherine?
I think you did when you went
Oh,
over the slide with I think it was the one under 70.
okay.
You can clarify.
Yeah, so for people, so basically our LDL goals for you are based on your risk. I would say for the average person, everyone's LDL cholesterol should be less than 100. If we can get it less than 100, it's better. If you have plaque, if you've got calcium in your coronary arteries, if you've got, you've already had a stroke or a heart attack, you've got diabetes, we may have much stricter goals for you because we know that the lower we get your cholesterol, the lower your risk is gonna be. And statin and the lipid lowering therapies that we have are generally overall quite safe. And so that's how we determine the goal.
Okay. Also a question about, is there any cardiovascular risk in women who take hormone replacement treatment or therapy?
So more and more we're learning that, again, it really depends on the person, but I would say that if women can take menopausal hormone therapy very safely. For the most part, we try and get you off hormone therapy 10 years after menopause. That's generally the guidelines. But for the appropriate, we don't use hormone therapy for cardiovascular risk prevention. But if you're using it for vasomotor symptoms, you're using it for your hot flashes, your mood changes, your insomnia because of menopause, yes, it can be really helpful. And your risk around menopause, it starts to rise in terms of your cardiovascular risk. It starts to rise. And partly it's because your lipids, you'll probably see this. If any of you have gone through menopause, you'll see that your lipids start to look bad. And they can look, even if they look really good before menopause, now they look terrible. And it can happen because of the change in the hormone. So a lot is shifting, but you can still safely use menopausal hormone therapy. We usually use the lowest effective dose, and we use a transdermal patch. We generally do not give you orals unless we have to, because it's safer to give you a patch. It's safer to give you a patch. But I would just work with your PCP or your gynecologist on how much and when to wean you off of hormone therapy. But we usually do try and get you off.
Great, thank you. And then last question, someone's asking if they're borderline pre-diabetes, A1C is 5.7, should they consider getting a CRP test or other related cardiovascular disease tests?
Yeah, like I would say that the way we determine your risk is not solely just by your A1C, but I think an inflammatory marker for anyone and everyone, especially if you've got a condition that's inflammatory like prediabetes or diabetes, I think an inflammatory marker, especially if you will take that information and understand how it relates to you, because I think that if your inflammation's high, that's going to be motivating. If your inflammation's low, it can be reassuring. Of course, it would ideally your A1C would be normal, also because glucose control does matter. And if you can get your A1C to be normal, that's also great. That would be great. But in terms of the calcium score, we really only use the calcium score in people who fall sort of in this intermediate risk category. And so generally speaking, I would say that most of my women, if I were going to screen them, I usually don't screen them until they're in their 50s, like mid 50s, something like that. If I've not already started them on statin for some other reason. And for men, earlier. Usually I'll screen my men sometime in their 40s. If they're not on a statin, and I feel like it would benefit from knowing if they have plaque.
Excellent. Thank you so much. And thank you for the presentation and everyone's engagement. Just letting you know that this recording will be posted on Stanford Health Library as well as our YouTube channel in the next week or so. And then you can see us back here next month, second Thursday at 5 to 6 p.m. for our next talk.
Great.
Take care.
Okay, thank you so much.
Thank you. Bye.
Bye-bye.